So what I was going to say, in general, give me some feedback. What are some things that could set one up to cause a vascular wound? Or, if you like, give me a general definition of what a vascular wound is. Okay, and that's a good general beginning. Something has gone wrong with your circulation or with the vascular system. So, what are some things that could go wrong with your circulation, to use your words, Haley, that might cause something that would lead to a wound? Diabetes makes everything worse, as we said before. Yes, it could. Now, if you've got a problem, diabetes will make it worse. If you don't have a problem and you have diabetes, you got a problem. That is diabetes itself. What I'm thinking of, thank you for that, Kim, but Pippi. Okay. That's fine. At least the last name matches. It's not a kitten like that lawyer a couple months ago in the video. So what are things that can go wrong with your vascular system, with your circulation, that might set you up for something going wrong, something causing breakdown in your integument, in your skin? Yes, like Allison said, diabetes will make everything worse, could possibly set the stage for causing your circulation problems. So how does having a circulation problem wind up causing a wound? Okay, that's one way. And specifically, what type of wound would that cause, Joey? Yeah, an arterial wound. So arterial insufficiency would cause an arterial wound. So that's one category. The other one, of course, is vascular. And there, I think still probably you could say it applies. What Julie said is a lack of blood flow. But there, it's not flowing to the periphery it's the problem. It's the flowing back from the periphery where we had that pooling just because of multiple factors. Both of those things, a venous insufficiency, both are considered vascular disorders. They're both considered peripheral vascular disease. So PVD is general. It would include both of those types. So with venous insufficiency, we wind up with venous blood remaining in the distal extremities, pooling. If you remember, the veins do not have smooth muscle underlining like arteries do. They are completely dependent. For venous return, you're completely dependent on residual arterial pressure and also the pressure of adjacent muscles adjacent to the veins. They have those little valves, and then veins do. So once it gets so far, it won't backflow. But the problem is getting it moving at all. So, as opposed to arterial wounds, venous wounds, it's not because there's not enough blood there, it's because there's too much and it puts stress on the skin. It can make it, it can cause it to become less structurally sound because of the prolonged stretch that's on it from the congestion, from the swelling. If it's to the point where it causes skin folds to occur, this would be a severe case. You have that skin-on-skin contact that happens within folds can lead to maceration, softening of the skin between that from sweat and some other things as well. And it's not at all attractive. I was at Washington Hospital the other day for an x-ray, and I tried really hard not to stare. I kind of stared peripherally at this guy. He had shorts on, and he had the dermatitis, that hemosiderin staining, where it was kind of a tawny color from about mid-calf down, the flakiness, the eczema, all those signs of venous insufficiency and venous disease. Everything except edema. So he must have been on some significant diuresis, I would guess, because he wasn't wearing any compression garments. That's an aside. Sorry about that. I'll try and keep those to a minimal out of respect for your time. Okay, so as Julie pointed out, lack of blood flow and arterial insufficiency. What's the problem that causes the wounds there? Yeah, blood's not getting there, but specifically, what does a lack of blood flow to an area cause? There's no repair of tissue. That's one thing. Expand on that a little bit, Julie. In addition to his tissue not being repaired because it's not getting the supplies. Right. So the wound itself usually doesn't come from the lack of blood flow. It can come from anything else. A pinprick, an abrasion, a blister, something like that. The problem is it's not going to heal because of the insufficiency. Now, that said, it can cause the wounds themselves to occur. Just because it's causing ischemia, that's the word I was hoping somebody would say, but ischemia causes a state of ischemia. Insufficient blood flow, not just reduced, but insufficient blood flow to the area. So it's possible that your arterial wound might just be the tips of your toes dying off. There's pictures in O'Sullivan and Schmitz, if you have that handy, where they've got the blackened toes, got dry gangrene. So that is that condition, and those wounds are directly caused by the lack of arterial blood flow to the area. I'm going to try and share my screen here. I want to pull up a Word doc. All right, you able to see that? Yeah? Okay, good. So just side by side, let me expand this. Side by side comparing arterial and venous wounds. So we have location swelling, the moisture, skin temperature, trophic changes, meaning what does it look like? What does the wound bed look like? Pain, comparing the two, what happens when the affected body part is elevated, and there's some other characteristics there as well. So my way of thinking, you guys know I love charts, just because that's how my mind works. I'm able to retain that information a lot better from looking at a chart as opposed to reading paragraphs broken down. Hopefully that works for you. If not, we can expand from there. But let's go through this chart first. If you think about it this way, for each of these topics, we're going to say this is what arterial would look like, and then this is what venous would look like. So the location of the wounds in arterial very frequently on pardon me, it could be the dorsum of the foot, could be the plantar surface of the foot as well, like under the met heads. The toes, because of that's the distalmost part. So those are, if there's not enough blood flow to sustain tissue being alive, that's where it's going to start, is at the toes. And very frequently along the lateral side portions of the foot. Okay? As opposed to venous, usually they're not on the feet. Usually they're proximal to the medial malleolus. Usually. They could be anywhere though. Okay? So this is not, you can't say for certain the wound is on the toe, therefore it has to be an arterial wound. That does not apply. There are some other things you have to, but that is definitely more likely to be an arterial wound. If we look at edema, is there swelling of the distal limbs? Usually yes, in the case of venous insufficiency, or if there's a venous wound. Usually there is significant swelling. May fluctuate, maybe more one day, less the other day, but usually there is edema present as well. Unlike arterial, you're not getting enough blood there, so there's nothing, you lack the fluid necessary to cause swelling. Okay. If you look at the wound itself, very often arterial wounds, they look almost mummified. The edges are dry and maybe crusty, the edges of the periphery of the wound, I should say. Very often the skin is flaky around that, and the wound bed itself is usually dry, or on the dry side. If you compare it to a venous wound, usually there is moisture. A wet wound bed, sometimes there's so much moisture, the moisture is just being expressed through the skin, which is gross if you don't know it and you grab somebody's leg. So, we have differences in location. We have difference in whether there is or is not swelling. Yes in venous, no in arterial. Moisture, arterial is dry, venous is wet. Skin temperature in arterial wounds, or a state of arterial insufficiency enough to cause a wound, usually the skin temperature is cool. Why? Because there's not enough blood there. It's maybe you would describe it as cold. With venous wounds, usually there's an increase in skin temperature in areas adjacent to the wound itself. Now, as far as appearance, other than what we've already listed, you tend to have, let's go arterial first. So you've got dry wounds, you don't have any swelling, you've got cool skin temperature. You may also see a lack of hair. Hard to tell if somebody shaves their legs or they didn't have leg hair to begin with. The skin also tends to be very dry. Looking at venous, we have that hemosiderin staining. That's that tawny color that I was talking about before. I know you've seen it somewhere, out in public for sure. Something called lipodermatosclerosis, where the skin, the dystrophic changes in the skin itself, and it actually becomes kind of tough and leathery. And then the next stage of that is the fibrosis of the dermis, where it does become very rigid and firm. Now, you don't see any leg models with with venous insufficiency. Looking at the wound bed. A healthy wound bed, if you were to look at a wound and some things you might be looking for, you want to see some nice pink granulation tissue, pink indicating good vascularity of the wound. You're not going to see that in a wound bed of an arterial wound. It's going to be pale because of the lack of vascularity. There may be some necrotic tissue or non-viable tissue is another way of saying that. There's going to be a minimum or maybe no granulation tissue. And if you remember our wound healing, without granulation tissue, you've got a chronic wound that is not going to heal. With a venous wound, it's almost always moist, and there is usually granulation tissue present as well. So those are two big differences in the wound bed itself. Now, I had someone argue with me, a Wheeling Jesuit student, argue with me that what I'm going to say is that arterial wounds are generally associated with pain more so than venous wounds. So if you had to answer the question, which wounds are painful, arterial or venous, the answer would be arterial. and she wanted to argue because she knew somebody one time who had a venous wound, and they said it hurt. Okay, well, that's one person one time, and that person never had an arterial wound, so there was no basis for comparison. So, anyway, but the wounds tend to be more painful. Arterial insufficiency is more painful than venous insufficiency. If you don't believe me, go get your blood pressure cup, pump it up to 200 millimeters of mercury, and leave it there for a few minutes. And you will experience that pain that you feel. That is ischemia. That is the lack of blood flow to a point distal to that. So, that's it. You can call that ischemic pain. The wound bed itself tends to be more painful than those of venous wounds. Now, that's not to say that venous wounds are pain-free or alternative sensation-free either. They may not report pain, but they may report heaviness, itchiness, fatigue, aching, and you see a lot of those terms when we talk about lymphedema as well. When the limb is elevated, you can see what happens, and that's another way you can differentiate between the two. If you elevate a limb, in the case of arterial insufficiency, there may be an increase in pain. Why? Because of gravity. You're elevating the limb, you're increasing the ischemia to the area, and therefore you can increase the pain as well. With venous conditions, in the early stages of venous insufficiency and venous wounds, the edema the swelling may be relieved in the early stages of that. Long-term chronic venous insufficiency and venous wounds, it's usually pretty static. Static as edema can be. Okay. But the big difference is elevation of a limb with somebody with a venous wound is not painful. It is with arterial. Other characteristics. There is a phenomenon known as the rubor of dependency. Rubor simply means reddening. So if you were to have, let's say you have your patient supine, you're going through an exercise program with them or something like that, a mat program, they have arterial insufficiency, and you have them sit up, and their legs are now dependent, what you may notice is they become quite red. And that's the rubor that we're talking about. The reason for that is gravity. Gravity is allowing arterial blood to flow down there. And then we elevate them, and they have pain, and they could also become less than normal color. It's called pallor, P-A-L-L-O-R. So, rubor of dependency, pallor of elevation with arterial disease. Chronic venous insufficiency and edema due to venous insufficiency may eventually become lymphedema. Just want to throw that out there. Okay, questions about anything on this document? Let's talk about some things that can lead to either arterial or venous insufficiency and set you up for this wound. Now, Allison mentioned diabetes mellitus. Yes, absolutely. That will, if you don't have something that caused peripheral vascular disease before you had diabetes, once you have diabetes, that by itself can eventually cause any of your systems to fail. So, what are some pathologies associated with either one, venous or arterial insufficiency? DVT, deep vein thrombosis. That's usually more of an acute problem. Although, once you have one, you're prone to having them further, and this is a completely unofficial, non-scientific collection, but the people I've run into who have had DVDs in the past, there does tend to be a tendency toward edema in whatever limb was affected there. But that's usually considered a more of an acute condition. Well, okay, DVT. The V is for venous, so that's not going to cause an arterial insufficiency, right? Different system. I think you're going too deep, Julie. Take a step back. I think cardio. What are some diseases you talked about in cardio? Heart failure is one. Okay, so which arterial or venous is that more associated with? Venous. And why? You have that congestion, right? The system backs up, and whereas if it backs up, it's going to collect somewhere. And where's the most likely place for it to collect? In the periphery, further away from the heart. And of course, we stand upright most of the time, so it's going to be lower extremities primarily. Okay? Good. What's another pathology? Oh, you know this. I know you do. We said before that peripheral vascular disease is a general term. Could apply to venous or arterial problems, right? So we got that. That's the big general heading. Now if we break down into some specific ones, somewhere in between PVD and something very specific, like Julie, what did you say, arteriosclerosis obliterans? Okay. What would be more general than that, but still referring only to arterial? No. Blood clots are almost always venous system. Oh, atherosclerosis. Plaque formation. Very, very common. It's probably written on about every 1 out of every 4 cigarette packs as part of the label. Okay. Now, not specific to wounds, but that's the same thing that would cause coronary artery disease. Same mechanism. You know, plaque formation inside of the arteries. It's a more general term than the one you use, Julie. So that would be like a subset of atherosclerosis, the obliterans. Okay. Characteristics. Let's back up a little bit. Talk about some of the characteristics associated with arterial insufficiency, pre-wound stage. Does anyone know what it's probably not number one, but it's a big complaint of people who have arterial insufficiency. It interferes with their function. Intermittent claudication. Yep. Intermittent claudication. And the intermittent part is important, Julie, because it's relieved with rest. Once you stop the activity and blood flow is allowed to return to the area, the pain is relieved. And then it's very often expressed in terms of distance that you're able to walk, because that's usually when people report it as part of their complaints. They say, I can only walk about a quarter mile, and then I get these crippling pains in my calf. That's a very common place for it, is in your calf. And then I stop, and after 5 or 10 minutes, I'm fine, and I can walk again for the same distance, and it happens again. That is classic intermittent claudication. And it's because the pain is from the ischemia. The demands of the muscle, requiring more glucose, more oxygen, are outpacing the ability of your arterial system to deliver those products because of the disease, whether it's narrowed lumens or whatever it happens to be. And mentioned before, the heart failure, congestive heart failure, is one of the most frequent things leading to venous insufficiency and venous system failure. Now, if we want to talk about specialty arterial insufficiencies, Jill, you mentioned arteriosclerosis obliterans. There's another one called, and this is hereditary, so you don't see that much of it. It's called thromboangiitis obliterans. It's also known as Buerger's disease, and it's hereditary. There's some linkage, Y chromosome linkage, so not exclusively, but it affects men more than women, or affects more men than it does women, even from the same parents. It is a progressive arterial disease that is accelerated with cigarette smoking. The only thing you can do to stop the progression of the disease is to refrain from smoking cigarettes or smoking tobacco products. Like I said, it's a small number, low number, but who knows, you might see reference to that somewhere. But it's the same as any other arterial disease in that the tissues are starved for nutrients and they die. Usually, in that case, of Buerger's disease, it's usually dry gangrene that does it. Fun stuff. You see people smoking with, they just got little nubs of fingers because they've had partial amputations over the years. And it's pathetic. Okay. You feel like you could tell the difference if I were to describe a wound to you? You should be able to tell whether it's arterial or venous, likely arterial or venous. I think that was an unconvincing head nod, Julie. You're like, yeah, maybe. 90% is. That's more than passing. More than passing. Okay, hang on just for a moment. Yeah. That's passing with a healthy cushion. Alright, just give me a moment. I had it laid out in another textbook, but then I decided I didn't like it. Let's see. Bear with me, please. While I'm looking for this, tell me, how do you feel about how prepared you are for pressure wounds? Okay. We'll definitely go over that again today. All right, I can't. Oh, you know what I forgot to mention? let's talk about this. It's an assessment instrument. It's called the Ankle Brachial Index, the ABI. Remember that? What it is, usually, you can do it with blood pressure, but usually now it's done with a Doppler ultrasound. And what you're looking at, blood flow to the lower extremities. And it's expressed in terms of arterial perfusion, and it's a ratio that's given. I said that, and I'm trying to find the table that gives the numbers for them. I don't think you're likely to see a number. I don't think you would see a question where somebody said the ABI is this number. What does that mean? I don't think you would see something like that. It would probably be more of a fund of knowledge question, seeing if you know what the ABI is associated with, and it's associated with arterial insufficiency. Okay, so if you have a patient is 78 years old, they have dementia, they can exchange a few words, but nothing of any consequence. How are you? I'm fine. How are you? Nice day. Just about that. But if you were to ask them any questions about their history or anything like that, they're not going to be able to answer you. They've been referred to physical therapy for wound management. So you are inspecting the wound, and you find, we haven't talked about odor. That's usually associated with infection, not necessarily venous or arterial. On inspection of the individual's skin, you notice her legs, or her whole person, she is slender, slight of build, legs especially so, skinny legs is another way of saying that. Notice the skin is dry and flaking. The wound edges appear necrotic. The wound bed itself is dry and pale. What kind of wound are we talking about? Why do you say that?
Well, the dryness of it.
You're right. I just want to make sure that it wasn't a guess, because it was a 50-50 chance, right?
The dryness of it. And I don't know, you said that she was skinny.
Yeah, so the dryness of the wound bed and the edges, peripheries of the wound bed, but I also said the skin itself was dry. Now, as an extension, if I asked, what would you expect the skin temperature in the area to be? Colder than normal, yeah. Okay, good. How about, what other things might you notice about her skin?
If you test for the rubor dependency, there will be a blood flow with the gravity feeding that.
Okay.
Blood is being pulled down.
Yep. Okay. You may notice, now, you wouldn't expect hairy legs on this lady anyway, but you may notice that there is a lack of hair in the legs, especially distal, lower extremities, and especially feet. Okay, good. Do you feel like you would be able to tell the difference if you were given characteristics of a wound? You would be able to say that's a venous wound or that's an arterial wound? Anybody? Anyone? Okay. Now you've probably seen, as a CNA, you've probably seen a good deal of both of those things. Alexis, you're extremely quiet.
The one thing I'm confused on
The answer's in the name. It's rubric of dependency. So dependent means if I'm sitting up, okay, my distal lower extremities are dependent to the rest of my body. They're lower than. Okay, so that's when. So if I'm lying down, the skin tone might match perfectly, and there might even be enough arterial flow to my feet, right? Because I've got what I need. If I sit up, though, as Joey said, you have the gravity that's allowing more blood flow to those distal regions, so you get that reddening that takes place. Okay, when your feet are lower than the rest of your body. When you elevate, you're going to have the opposite. It's going to be more painful because you're increasing the ischemia, and it's also become more pale if the skin tone allows you to visualize that. You sure? Okay. Smoking cessation is the single biggest thing that will help slow the progression of any vascular disease. So, someone could do all kinds of other things, take every other bit of medical advice except still smoke, and that disease is going to continue to progress. It's as simple as that. Okay, ankle brachial index. It is associated with, it's used as a predictor for the likelihood of arterial disease, not venous disease. It's a measure of the blood flow to the distal extremities. They use a Doppler ultrasound now, but it got the name ankle brachial is because you would take blood pressures in both the upper and then the lower extremity and you would compare them. All right, I am going to get rid of this screen here, if that's okay. Maybe. Pressure wounds. Confusion. Someone said there's confusion over grading. Okay, how many grades are there? There are 4. And what are they called, Grace? Exactly, yes. It just goes by the numbers. But there's actually 5. And the last one's not a number, and that is unstageable. And the reason that exists is because part of the staging process, or part of how you classify what stage a wound is for 3 and 4, where you have a wound bed, is what's visible in the wound bed, how deep is it gone. And if you can't see because of eschar or slough or some other junk, or it's tunneling because underneath the skin surface, so you're not able to just view down on it, then you can't tell. So you don't guess. You say it's an unstageable wound. So what's a stage 1? Redness. What redness to what? What's that? Oh yeah, redness of the skin, but there's an important part of it. When you take off your shoes, are your feet red? Do you have red spots? Like if you take off your bra, you have red marks on your skin there or something like that when you first take it off? Grace does. She says, I don't know. But, I mean, that's normal. You've had pressure there. So why is that? Why don't we call that a stage 1? Okay, but how can you tell? So let's say you're assessing someone's skin, and you see a red mark. How can you tell right away, whether that's something to be concerned about or whether it is not. I mean, if it's still there tomorrow again, then yeah, that's a problem. But you want to know right now. Haley, do you know?
I think you're looking for like it's non-blanchable or like a capillary refill.
That is exactly what I'm looking for. That is exactly what I'm looking for. So when you, in the privacy of your own home, find a red, when you get undressed tonight, find a red spot on your skin that was caused by clothing, press on it. If it turns white and then pink or red again, then that's good because you have capillary refill. That's the words Haley used, and they're exactly right. So you still have blood flow to that area. If, however, it does not change color, well, then you have damage. So that is a stage 1. And that's how you tell just a regular red mark compared to a stage 1 pressure injury. And pressure injury is the preferred terminology because ulcer implies that it's an open sore, and of course in stage 1, there is not. So what we call that, if you want to use some fancy language, a stage 1 pressure injury is non-blanchable erythema of intact skin. So there's no opening, it's not blanchable, it's red and not blanchable. That is a stage 1. Now we say red, but there is some implicit racism built into most of the medical system. If you have dark brown skin, you're not going to have a red area, but it will be different in coloration than the surrounding skin, and that's what you're looking for. Does it change when you press and then change back when you relieve the pressure? Okay, then you do have capillary refill. If it doesn't, if it stays the same alternate color, then you're probably looking at a stage 1. Stage 1, I'm going to repeat this, a non-blanchable erythema of closed skin, intact skin. Okay, that's stage 1. I'll also mention, remember, these stages are only used for pressure wounds. You could have a wound from a burn or a deep abrasion or a laceration or something like that, and they might look very similar. Like, oh, I can see the fascia, or it's all the way down the bone, or whatever. Doesn't matter. These stages are only used for pressure injuries. Stage 2, now we have some type of disruption of the skin. It's a partial thickness disruption. It could be a blister. It could be the epidermis is worn away. We do have what we're going to call a wound bed at this point. Okay. What's visible in that wound bed? The dermis is visible. We're not seeing anything deeper than that. We're also not going to see granulation tissue. The skin heals in a different format. We're not going to see slough. Slough is the stuff that runs out of a wound. It could be any variety of substances that make it up, or something called eschar, which is kind of a hardened slough. That is. We're not going to see any of those in the stage 2. Okay. Those are the big things. These often occur at stage 2. Think about a blister. Abrasion can cause it. Shear forces. So you're transferring somebody, you're repositioning them in bed, and you kind of drag their bare butt across the sheet, or your heels, or whatever body part. And if you can picture someone of advanced age, one of the changes that happen, one of the wonderful changes that happens to us as we age is that our dermis thins and becomes more fragile. So it doesn't take very much. You can damage skin a lot faster with a shearing force because you're kind of pulling the layers apart. You can get an injury, only takes a second to get an injury that way than with unrelieved pressure. But we're still going to call because there was body weight involved, those are still, even if due to a shear force, it still falls under the category of pressure injury. So it's partial thickness, maybe a blister, maybe not. If there is a blister, then it's not a stage 1. Now when we go to stage 3, we have lost the full thickness of the dermis. There's no epidermis, there's no dermis over the affected area. So stage 4 is also a full thickness injury, but what is visible is how you tell the difference between 3 and 4. In stage 3, you might see fat, adipose tissue. And subcutaneous fat is what you'd be seeing. Often there's a granulation bed. We're not going to see that in 1 or 2, but we may see a bed of granulation tissue. We may also see in stage 3 slough, eschar, exudate, if you will. We're not going to see that stuff in 1 or 2. Now, there are conditions called undermining or tunneling, it's the same thing, that may occur, where you may have an opening this big in the skin, but the wound actually might be this big. It extends underneath the skin. Okay? If you can see all the areas, if you can visualize through the wound, even if it's bigger than the hole in the skin, if you can visualize the entirety of the wound bed, then you can still stage it. But if it goes way off somewhere and you can't see where it goes, then it's unstageable. Because it's too great for you to accurately say that, yes, it is, all the areas are this. Pardon me. Now, so you may see fat. What you're not going to see muscle, you're not going to see tendon, you're not going to see bone. And of course, if it's full of cucus, slough, stuff, you're not able to see the bottom of the wound bed, it's what? Unstageable, that's right. Now I just said you're not going to see fascia, muscle, ligament, tendon, or bone in a stage 3. Where are you going to see those? Stage 4. Okay, and that's what differentiates a 3 from a 4. You could still have all the other things, the slough. You could have undermining. You could have tunneling. You could have something to prevent you seeing the base of the wound bed, which then is unstageable rather than a stage 4. So there's stages 1 through 4, and then there's the extra one, which is unstageable. You okay with that? The staging? Allison, where'd you go? Yeah, I've heard that about Frontier. Windstream's not a whole lot better. I really struggled with class the other day. Anyway, that's my problem, not yours. Okay, so we're going to pressure injuries. Only pressure injuries get staged like this. Other wounds would be described in terms of a lot of the same things. What's the area? What's the depth? What's the wound bed look like? Is there an odor? What's the moisture content, or what's the moisture level? Meaning, is it dry? Is it wet? Is it really, really wet? Or is it really, really dry, like mummified jerky? So you use those descriptors to describe other wounds, but not the staging. system. Someone could have a chemical burn that takes things all the way down to a joint capsule, which, if it were pressure injury, would be a stage 4. But it wasn't caused by pressure, so we don't use that system. What else do you want to hit? Should we talk about lymphedema, do you think? Much more likely to have pressure injury questions than lymphedema questions, but not necessarily exclusively. Yes, no, something else instead?
I don't know. I'm gonna say just like touch on lymphedema just to like give a review.
Okay.
That was gonna be my question. If you think like it's something that you feel like it's. I mean, I know it's hard to tell.
It is. It's impossible to tell, really. Theoretically, it is testable. I'm going to say it is less likely to show up, at least less likely to have a number of questions than some other things. But this other systems is an area that has been a challenge for our graduates historically. Why exactly, I'm not sure. Part of it's because there's so much. And I've had, you're not allowed to discuss specific questions after you take the test. That's part of the agreement. But I've had students tell me one year, oh, there were a ton of questions about prosthetics on there. And then the next year, I said, were there a lot of questions about prosthetics? No, but there were a lot of pediatric questions. So that makes it really difficult to say what's going to be on there. However, that said, lymphedema tends to be an area of specialization. You can become, as a PTA, you can become a certified lymphedema specialist. There's one who works for OSPTA. She's a PTA and does that, travels. She hits many offices because you're not going to be in one area and have enough lymphedema patients to fill your days every day. So, but it is there. So let's talk on a little bit. Generally, when I was in school in the 1900s, we were taught aggressive retrograde massage for lymphedema, followed by compressive garments or dressings of some type. That line of reasoning has changed. Now it's a very delicate massage that's applied. The thought being, this is probably more information than you need, I apologize for that, is that when you get really aggressive and start pushing fluid back this way through the skin, you're actually causing a lot of the lymphatic vessels to close down. So you're pushing that fluid around, but it doesn't have anywhere to go. Where a more, almost like an effleurage type thing, in a controlled manner in a retrograde direction, is recommended rather than that. Shove that fluid back up there, which is the way I learned. With the compressive dressings that are, don't try it. You need training to do it. And they look fancy. I mean, they look like almost like origami or some. You see the people decorating cakes. They make these really complex flowers. That's kind of what it looks like in between the fingers or toes, whichever limb we're talking about there. Okay, what it may be represented though as part of something else. A very common way to develop lymphedema is to have breast cancer, or more specifically, to be treated for breast cancer. Because very often, because when you do that, I mean, there's a lot of lymphatic vessels there. When you're treated for cancer of any type, very often adjacent lymph nodes are removed as well, as a precaution for potential malignancies. because that's what lymph nodes do. Is they help fight invaders. Other type cells. Cancer being one of them. So they may become. Technically, it hasn't metastasized yet. If you don't know it's there, but the risk is real enough that they'll take lymph nodes. Well, the good news is you've eliminated the possibility of cancer cells being in that lymph node because it's gone. The bad news is you have disrupted your lymphatic system. That's why there's such a strong association with breast cancer and lymphedema. It is not, far from it. It's not the only way that you can obtain lymphedema, but it is probably the primary way. There is one form of lymphedema, which is just your bad luck, picked your wrong parents. And it's just kind of, I think it's called primary lymphedema, but don't quote me on that, let me look it up. The volumetric measurements are a big thing with lymphedema because you have to keep track of lymph volume. That's the way you would, that would fall into the anthropomorphic measurements. And I think that would probably be under no system because you're talking about an assessment tool, but still, it's there. I'm trying to find it in here. You've probably heard me say this before, I really don't like how Chapter 14 in the Sullivan-Schmidt is arranged. I'll tell you what pressure ulcers are on this page, and then 10 pages later they give you the scale with the description of the stages. The same thing with lymphedema. I don't understand why they do that. So lymph, it's that our blood vessels are leaky, and the stuff that leaks out gets transported back to the central circulation by the lymphatic system. Okay? So if we have something that disrupts that transport system, that lymph will accumulate in the periphery. Could be upper, could be lower. If it's breast cancer, it's usually upper extremity, but it doesn't have to be. I was right. It is primary lymphedema is the congenital form. So that's just bad luck. So secondary is the other form. Lymph vessel disruption, lymph node disruption is something that is likely to set you up for lymphedema. It could be an injury. It does affect women more than men, but not exclusively. I've met men who have lymphedema for one reason or another. In the early stages of lymphedema, you may have relief of edema or a reduction in edema with elevation. But in later stages, it brings no relief. And it becomes, in the later stages, it becomes very similar to late stage venous insufficiency as well. You have the same changes in the skin, the fibrosis, the discolorations, the trophic changes in the skin itself, just like in venous insufficiency. It is a fairly common disease. Maybe eventually that might be something you want to look into to make yourself stand out a little bit more. A couple things that you look at for lymphedema, pitting or not. And I'm trying to find more detail about that because I know first you don't have pitting, then you do, and then you don't again as the stages progress. So bear with me as I suffer through this crazily, is that a word? Crazily? Yes. Oh, share, please. Yes.
So there's 0 to 3 are the stages. 0 if they had lymphedema, it's still there's an abnormal lymph transport. You just don't see it if you're doing it.
Okay.
Stage 1 is early edema that improves with elevation. Stage 2, hitting edema unresolved with elevation. And stage 3, fibroadipose deposition and skin changes.
And
I don't know how, I'll have to figure out how, but I could send this handout that I made.
you just have a hard copy?
Yeah, I could send it, but not right now.
Yeah, yeah. No, I was thinking about how you could share it with a group.
Well, I have it on my computer, but I can try it and see. If you want me to, I can use it.
Oh, no, actually, I meant with a group like with your class. Because if you have it as an electronic document, you can upload files to Facebook.
One other thing, there's what's called the stemmer sign, STEMMER.
Yes.
Can you pinch on the dorsum of the hand or the dorsum of the foot? So if you're unable to pinch the skin, that's considered a positive stemmer sign. So that's positive or negative.
I recall that now that you say it. Thank you for mentioning that.
And also the other thing is the severity. So a mild case of lymphedema is less than 20% decrease in extremity volume. Moderate is 20 to 40%, and severe is greater than 40%.
Oh, okay. Now that's for me. That's new information. Thank you.
And that's done by, there's several ways that information, that anthropomorphic information is gathered. Bioimpedance is one, limb volume measurements, and I saw it done in the field because I got to travel with Alexis Frank.
Oh, okay. That's who I was talking about. Yeah.
Spend a week with her. She's excellent. So in the field, she was using the tape measure.
Doing girth measurements.
Girth measurements, yes. And all lower extremity. I don't recall. Well, no, I think that there was one upper extremity. Most of them were lower extremity. Measurements can also be done by water displacement.
Yeah. That last one doesn't sound familiar to me either. Wasn't me. Very good. So you're more up to date than I am, Julie.
I had that excellent opportunity. So if anyone ever gets a chance to follow Alexis around, I highly recommend it. She was also at the same time she worked with the OCPA patients. She's also working a second job with young children. So I didn't get enough time with her. I wanted to spend talking.
Like a early intervention type thing, or?
I don't recall the name of the company. It was a different company. But she was home health. She was a home health and doing home health with them.
Okay. Nice. Nice. So, I'm glad Julie was here, Grace, because she had the answers much more accessible than I did.
Yeah, if you can see if you can upload that, really, that would be great.
Do you have a recommendation? Do I just write it to Facebook? Do you have a recommendation of how?
Yeah, I mean, you could probably just like take a picture of it if you're gonna do it to Facebook, and then just post it on that class site or class page. I would just do a picture. picture of it if you're near.
Yeah, I think a PDF will work as well.
You might, so which is easy. I mean, I have the file. I mean, I have it on my computer. You just open it.
Yeah.
Just upload it. Okay, I'll try. I might be calling. I might be messaging you.
Okay. We'll figure it out, but that's really handy information to have. So compression is a big part of lymphedema treatment, which, as Julie was talking, I realized I wanted to mention that compression, and you might remember from modalities, is contraindicated in the case of arterial insufficiency. Because you've already got limited blood flow, you start squeezing down on that, you're going to limit it even more. Whereas compressive therapy is very useful and very common in treating venous insufficiency. Usually people are told if they have compressive garments, compressive socks, which go all the way up to the knee, and they're graded so there's what's the word? There's a pressure gradient. The pressure is greater distally than it is proximally to allow that excess fluid to be moved up. They're told put them on when you get out of bed, take them off when you go to bed. You don't need them while you're in bed because if you are pretty much horizontal, that's considered to be. And when you first wake up in the morning, because of spending time relatively horizontal, that's usually when you have the least amount of edema during your day. So if you put them on at that time, rather than trying to get rid of edema, you're helping to prevent the accumulation of or formation of edema. You guys okay with burns?
I actually did mine service from spring irritation on that, so I feel like I'd be okay, but
You want to tell everybody else what you know? Like Julie did about lymphedema?
If you don't mind, because I'm confused, partial thickness, all those.
It gets, yeah. One thing you should be aware of, you should remember, is the rule of nines. If you don't remember that, go back and look that up. The accumulation of body area, and also bear in mind it's different for adults than it is for children because of difference in proportions. Bigger head, right? I think burns is in the same chapter, is it not? So it's similar, but not to be confused with the staging for. Oh no, burns are their own chapter. That's right. Pardon me for a moment. We do them close to the same time. Chapter 24. So, because we're still talking about the thickness and how much of the skin is involved, but they're not caused by pressure, obviously. They could be caused by heat, right? Thermal burns could be caused by chemical, could be caused by electricity, although electrical burns have some specialties to them. Okay, so we'll begin with the least, or the least severe stage, which is epidermal. Okay, that's just your epidermis. This is you get a little red from the sun. There are no blisters. The skin surface is dry. Probably painful and tender. No blisters. When you heal from an epidermal burn, there are no scars. They heal spontaneously. We've got two categories of partial thickness. We've got a superficial partial thickness burn and a deep partial thickness burn. Okay? With superficial, we've got part of the dermis, all of the epidermis, part of the dermis. Okay? Deep, I don't want to get into the different layers, the Rette peg and all that business, but there are actually different layers to your dermis. So let's just say partial, superficial partial thickness, all of the epidermis, a little bit of the dermis are involved. So what's it look like? Bright pink, bright red, could be mottled, swollen, or inflamed. Blanching, it'll blanch, very brisk capillary refill, and probably lots of yelling from the person who has it because you're pushed down. You could have intact blisters with this one. There may be weeping of the skin or from blisters as a release of moisture. Usually very painful, usually very sensitive to changes in temperature. You might be freezing, you might be really hot, you get in the shower and you can't stand either the temperature or the force of the water on your skin because it's so sensitive. Even a breeze might aggravate it. You could have more swelling with this one. The healing is spontaneous. It just happens. Stay out of the sun and it'll happen, or whatever happened to cause it. Okay? It could be thermal as well, but this one usually you're talking about could be hot liquid, but the most common is people staying out in the sun. Minimal scarring with this one. There may be some, but it'll be minimal. And there may be some discoloration as well. The discoloration tends to affect people with darker pigmented skin than lighter. Okay, that was superficial partial thickness. Deep partial thickness. We've gone deeper down into the dermis, but not all the way through. Okay. We've gone deep enough to destroy, impair some of the sensory receptors, so these are not as painful. It's a more severe wound, more severe burn, but not as painful because of the destruction of some of the sensory receptors that were in the upper portion of the dermis. So this might look kind of red, kind of mottled, can look kind of waxy, white. That's not good. Very slow capillary refill for this one, where superficial partial thickness we had very brisk capillary refill. Here it's slowed. If you had blisters, they're probably broken. The surface is probably wet. As I mentioned, it's not going to be painful. Probably will have pressure sensation, but none of the others. And that's because pressure receptors are deeper. They lay deeper in the dermis. Now, healing may still be spontaneous, but it's going to be slow. It's going to be slow. If you think back, slow capillary refill, that means not a great blood supply, so everything's going to happen slower. There will be scarring. There may be significant scarring with this one, just because of the amount of the dermis that was affected, and not in a good way. Probably severe edema as well. Okay, goes epidermal, which is just the epidermis. Superficial partial thickness, deep partial thickness, and next is full thickness. So with the full thickness burn, the skin's gone, right? It could be white or it could be black because it's been charred, or a variety of other colors, all but the color of normal skin. The surface appearance is going to be dry, kind of, it's described as parchment-like. No sensation. because all the all the receptors have been destroyed in this area. If there's still hair present, you could just pull it right out because the follicles have been damaged as well. Now, this is not going to heal by itself. There has to be skin grafting with a full thickness. The area, when it's fully healed, or as healed as it's going to be, will probably be depressed. That means lower. So if I had this area of my skin that had a full thickness burn, and I had a graft and all that business, there would probably be a depression there once everything was healed, or as healed as it's going to. And there will be scarring. There'll be significant scarring here as well. Now, in a subdermal burn, that means all of the skin and some deeper tissues as well. Looking at the wound bed, you'll be able to see some of the subcutaneous tissue, whether it's adipose or whether it's some of those other things like joint capsule ligaments, tendons, muscles, bone, for example. There's probably going to be some muscle damage, and there's probably going to be some neurological involvement as well with a subdermal burn. There may be more than skin grafting that's necessary. There's a muscle flapping. I don't know if you ever heard of that procedure where they take a healthy adjacent muscle and they take a portion of it and kind of turn it around so it covers the area, and then it becomes grafted in place. It's still covered with a skin graft as well. Those are the stages.